the medications by infusion, whether it is antibiotics or other medications given by infusion. Administer blood and blood products. Of course, we need an IV access for the blood and the blood products like the plasma, like the platelet, like the cryopretate or the factors. And as I said, administer medication, whatever the type of medications given by the IV infusion, or sometimes diluted with a fluid, so the IV fluid, or sometimes a slow IV, direct IV infusion. And sometimes you provide parenteral nutrition for those patients with debilitated patients, the chronic illness, they cannot take orally. So those patients should be replaced with total parenteral nutrition, given amino acid or lipid through the IV line, but here should be through the central IV line. And to provide an avenue for diagnostic tests. When you put an IV access, you can draw the blood for investigations while you admit the patient, and no need for more puncturing of him or for further test of blood. So in general, these are the reasons of the infusion or putting an IV line. Now, in our session, we will talk about the IV fluid. As you know, the IV fluid is essential and the fixed and the shared element of the management of many diseases. Almost always, all the patients admitted to the hospital, we give them IV fluid. The IV fluid may be given for the replacement, for rehydration, or for maintenance, or to give medication through the IV fluid. So as I said, we should know the type of IV fluid. Now we will talk about the types of IV fluid. Chemically, how many types of IV fluid we have? Chemically, according to their constituents. What are these types?
Crystalloid, colloid.
So chemically, or according to their constituents, we can divide the IV fluid into two major categories, the crystalloid and the colloid. You know, we give the IV fluid through the IV line. So it is inside the intravascular compartment. And there is a relation between the intravascular compartment and the extravascular, whether it is the interstitial or the intracellular. So, you know, the cells have a semi-permeable membrane. So according to the semi-permeability of the membrane, there will be a movement of some particles of low molecular weight through the semi-permeable membrane, or it may be prevented if it is a high molecular weight. This is for a certain type of fluid called the colloid. But we mean by crystalloid is just a sterile water, and added to it either electrolytes like the sodium, chloride, or potassium or calcium, or sometimes we added glucose. All of these or part of these. So as example, the most common example it is, and the famous, it is the 0.9% normal saline, or the correct pronunciation is saline, not saline, and the Ringer lactate. These two types of fluid used for the initial rehydration in the patient with hypovolemia or of dehydration. And this is needed, and we will know why this type of fluid is needed for the rapid expansion of the extracellular fluid compartment. And of course, we mean the intravascular specifically. Another example for the crystalloid is the 5% dextrose. And we may have other types of crystalloid fluid. We will go to talk about them during the course of this session. The other type, as I said, or the other category is the colloid. Here is different in concentration and composition from the crystalloid. Here is a heterogeneous fluid with large size particles, or what I say, a high molecular weight. And this is with a low permeability, so it cannot pass through the semi-permeable membrane from the intravascular or from the extracellular to the intracellular. And of course, will make a rapid expansion of the extracellular fluid compartment because it will stay at this compartment. And the common example for this is the plasma and the 5% albumin, even 20% or 25% albumin. We can consider the albumin and the plasma as a natural colloidal fluid. And we have the synthetic colloidal fluid like the hemosil and dextran. So they are used for the rapid expansion, but actually in this time or nowadays it's used rarely, and it is not the first line of rapid expansion, and it's sometimes not used alone. So as I will repeat, crystalloid and colloid according to its constituents. Now, the crystalloid fluid can be classified again into three types according to osmolarity. You know, the IV fluid, it may contain sodium with glucose, or it may contain sodium alone, or it may contain glucose alone. The presence of sodium and the glucose in a certain concentrations or in a certain osmolarity will divide or will classify the crystalloid fluid into three main types. So it may be isotonic. And when we say isotonic, we mean the osmolarity is between 250 to 375, which is through this range, the normal osmolarity of the plasma is placed. So what is the normal osmolarity of plasma?
285?
Yes, very good. 285 to 295. This is the normal osmolarity of plasma. So through this range, or in this range, this is called the isotonic fluid because it is near to the normal osmolarity. So because it is isotonic fluid, there will be no shifting of a fluid after we infuse it from the extracellular to the cellular, because it is isotonic, near to or the same of the osmolarity of the plasma. So it will increase the extracellular fluid volume, and that's why we use it in the resuscitation fluid or in rehydration. The examples are the normal saline and ringer lactate and 5% dextrose. But 5% dextrose have a special note we will talk about later on. The other is hypertonic. Here is, from its name, the tonicity or the osmolarity is much less than that of the plasma. So it is less than 250 milliosm per liter. And because it is hypertonic or decrease in its osmolarity, this will necessitate a shifting of a fluid from the intravascular to the intracellular and interstitial space. Because, you know, the aim is to maintain the osmotic pressure equal or balance in between the two compartments. So there will be shifting from the extracellular or from the intravascular to the intracellular. The examples are the half normal saline. You can see here, this is the normal saline, which is about 0.9. So when we say half, it means 0.45%. When we say the 1/3 of normal saline, it's mean 33, of course. And 25, it means the quarter of normal saline. And when we say 1/5, it's mean 0.18%, of course. And if we go to the dextrose water, we consider the 5% is isotonic. So the 2.5, of course, it will be hypertonic. The other group of fluids, according to the osmolarity, is the hypertonic. Here is the tonicity or the osmolarity is more than 375. So it's not just 375, it is 375 and more. And because it is hypertonic, or its osmolarity is high, so this will begin the movement of the fluid from the intracellular to the interstitial to the intravascular. So this will increase the intravascular volume or the intravascular compartment. Examples are the 3% of normal saline. This is mean 3 times 3% normal saline. It means 3 times the concentration or the osmolarity of normal saline. 5%, it means 5 times. And the other example is when we combined 2 isotonic fluid components in the same solution, it will give us a hypertonic fluid. I mean, like the 5% dextrose, if we combine it with the normal saline or without normal saline, so the natural result will be isotonic with isotonic or isotonic with hypertonic, it will give us hypertonic. The other example is the dextrose, 10% of dextrose water. It is the multiplication of the 5%, and we have also the 20% and even the 50% of dextrose water. So we should know the type according to osmolality. Now this picture can show the movement of a fluid from the intracellular to the extracellular. In isotonic, because its osmolarity is the same like of plasma, so there will be a balanced movement of water or fluid in general between 2 compartments, so the cell will take its normal size and its normal function. While in hypotonic, because it is low in its osmolarity, so as I said, the movement or the shifting of the fluid will be from the extracellular to the intracellular. And of course, the net result for this will be the cellular edema, a swelling of the cells and cellular edema. And if we talk about a certain tissue, it will be dangerous and life-threatening. Like what?
Cerebral edema?
Of course, cerebral edema. And sometimes it may lead even to rupture of the neurons, or after the profound swelling of the cells because of the edema. On the other hand, if we talk about the hypertonic fluid, because it is hypertonic and the body needs to maintain the osmolarity between 2 compartments, so the shifting of a fluid or of water will be from inside the cells to the extracellular and specifically to the intravascular. And this will lead to the shrinkage of the cells and what's called the cellular dehydration. And again, if it happens in the brain, it will be serious because it will cause to what is called
Osmotic demyelination syndrome?
They call it central pontine myelinolysis. This is a life, it is, although it is rare, but it is a life-threatening condition. The central pontine from the pontine, you know, the pons part of the midbrain, and myelinolysis, it means the lysis of the myelin cells. So it is a critical and life-threatening condition. Sometimes we get these disturbances from the primary pathology. That means the dehydration itself. If it is hypotonic dehydration, it may cause the hypertonic dehydration. It may cause cerebral dehydration or cellular dehydration. But sometimes, because in our session now, we talk about the IV fluid, so we talk about the epidemic. We will know what are the indications, contraindications, or the cautions to avoid these life-threatening or critical conditions when we use a certain type of fluid in a certain situation. Now, this is another picture showing or explaining the movement. So here in the hypertonic hypotonic and more fluid, so it will pass to the cells, causing the swelling of the cells. This is in hypertonic, while in isotonic, it is a balanced amount of the sodium and water. So the movement will be also balanced, and there is no shifting of the fluid, and the cell maintain the concentration and its physiology. And in hypertonic, when we say it is more than the 375, where the movement, the shifting will be from the cell to the intravascular compartment, causing increase in it, and of course will causing dehydration of the cells. Now, these are the constituents of a group of crystalloid cells. When we say normal saline or normal saline, as we used to pronounce, we say it is the nearest to the osmolarity of the plasma, but it actually contains just sodium and the chloride. And the concentration, as you see here, the 154 for both. So when we say it is half, of course, the concentration will be half. When we say it is a quarter or fourth, the concentration will be like this. The other is the ringer lactate. Ringer lactate, it contains sodium, chloride, potassium, calcium, and lactate. So physiologically, it is the nearest to the plasma. But in its tonicity or its osmolarity, the nearest one is the normal saline. Why physiologically? Because it contains potassium and calcium and even lactate. You can see here the concentration of sodium. The concentration of sodium, regarded relatively, is less than that of the less than that of the sodium, while the chloride is nearest to the normal serum chloride. Of course, when we talk about the dextrose water, according to the percent, we know the concentration of glucose inside it. And if we talk about what's called the glucose saline, so of course we talk about these constituents that's shown in this table, adding to this dextrose and 5%. Now, this table shows the osmolarity. You know, the normal osmolarity of plasma. So the normal saline, it is the nearest, 308. While the ringer lactate, it is also isotonic because it is near 273. Dextrose water is also, because it is more than 250, it is within isotonic. And dextran, which is a type of colloid fluid, is also isotonic. It has the same osmolarity of the normal saline because the presence of the normal saline in its constituents. While when we say hypertonic fluid, so these examples for dextrose 5% and half normal saline, and this is dextrose 5% and full normal saline. So its osmolarity is higher and it's more than 375. That's why we call it, or we regard it as hypertonic. Remember, this is a combination of two isotonic fluid, or one isotonic with one hypotonic, making it hypertonic. Because, you know here, this is half normal saline. If it's alone, it is hypotonic. And dextrose 5% alone, it is isotonic. But when we combine it together, the result will be hypertonic fluid. Now, after the types of fluid, according to its constituents chemically and according to its osmolarity, we should know the classification according to its use. And the use is determined previously by its osmolarity. So we have three types of a fluid, or we can say three clinical uses: resuscitation fluids, replacement fluids, and maintenance fluid. So now I will ask you, think of the answer. According to the group, don't give me the name of a fluid, give me a group of a fluid. Which is appropriate for resuscitation? Isotonic, hypertonic, or hypertonic? Why?
Isotonic.
Why isotonic?
Doctor, it is the best to increase the extracellular fluid expansion.
Without shifting of the fluid from the both compartments. Very good. While a replacement fluid and in maintenance fluid, we can use the hypertonic, or sometimes we can use the hypotonic accordingly. But in resuscitation, of course, always we should use the isotonic fluid because we need to increase the intravascular compartment without shifting of a fluid and without changing the osmolarity. So, in resuscitation, can we use colloid fluid or just the crystalloid isotonic?
So we can use colloid, but the first line is crystalloid.
Very good. Now, the first slide in this session is to comment on each example of a fluid. As we said in taking history, you have to define the patient in unit and you have to put a profile for your patient. Here you have to put a profile for the IV fluid. So you have to say this is a crystalloid, this is not a colloid fluid, and you have to say this is a isotonic fluid. You have to know its components. It contains sodium chloride alone. The concentration is 54, and its osmolarity is 300 point. This is the ID of this fluid. You should know it. And of course, it's used in resuscitation. Now we will know what in details, what are the indications of use of this fluid and the contraindications or the cautions in using this fluid. So, in uses, of course, we say in resuscitation. So it is the fluid of choice. Always you can use the normal saline for the shock, whatever the cause, and for resuscitation safely. It is the most safe, or it is the safest fluid to use in the resuscitation and the early management of shock. Another indication of use in metabolic alkalosis. Anyone can tell me why we use a normal saline in metabolic alkalosis? Firstly, can you give me an example of metabolic alkalosis? We can suspect it or see it daily in emergency departments of pediatrics.
Vomiting.
Very good. Very good. Especially isolated vomiting. Because in isolated vomiting, we have a lot of electrolyte changes and acid-base impulse. And recurrent and repeated vomiting, especially when we talk about the isolated vomiting. So there will be a loss of potassium through the gastric loss, and we will the patient will lose chloride, so the patient will have hypokalemia and hypochloremia. And the most obvious example for this is in the congenital hypertrophic pyloric stenosis because of the chronicity and the frequency of the vomiting. So this is the hypochloremia and the hypokalemia. So from where the alkalosis come? Why the patient?
Losing
with
hydrogen?
what?
Losing hydrogen in HCl?
Very good. He will lose the hydrogen ion, HCl, through the vomitus. So he will have metabolic alkalosis. Now, given normal saline, you know the normal saline composed of sodium and the chloride. Chloride has a feature is can use by the kidney, making a shifting with the bicarbonate. The body or the kidney, the renal tubules, can excrete the bicarbonate and shifting with the chloride. So that's why the bicarbonate will be lost and the chloride can be make a change with it. So for this reason, we use the NaCl or the normal saline in metabolic alkalosis. In cases of hyponatremia, whether in eovolemic hyponatremia or in hypovolemic, I mean in hyponatremic dehydration, we can use the normal saline. In DKA, of course, in management of DKA, the initial shot of a fluid given in resuscitation, it will be the normal saline. Heavy drainage from the GI suction, fistula or wound, this is in surgical situations, but of course the fluid of choice here is the normal saline. Now the normal saline has a special advantage on other type of fluid. That is, it is the only solution that should be administered with the blood products. When you try to give a blood product, you can't use other type of a fluid because it will affect on it. So the only is the normal saline. And sometimes even when you give a blood, certain type of fluid is contraindicated to be given at the same time or to given at the same IV line. It's not always safe. You should use it in caution in cardiac or renal diseases. Why? Why the cardiac? Yes?
Risk of volume overload?
Very good. Because this is an IV, an isotonic fluid, it will increase the intravascular volume. So, or with renal insufficiency, it will may cause volume overload, and it may cause pulmonary edema or peripheral edema, worsening the condition of those patients. So these are the cautions. Now, we will go to other example, which is ringer lactate, and you have to comment on it. This is a crystalloid isotonic fluid. Its component is the sodium, the chloride, the potassium. You should know it. Even the concentrations, the calcium and the lactate, and sometimes we have ring lactate, and sometimes we have what's called a glucose ringer lactate. It's mean adding 5% dextrose to the ringer lactate. Now the osmolarity is 273, and we say it is the nearest fluid physiologically to the plasma because it contains the potassium, the lactate, and the calcium. Now, we will know the indications or the uses of the ringer lactate. What is the first indication to use? First indication to use ringer lactate.
In resuscitation أيضا إذا ما كان normal saline.
نفس النورمال saline غير.
It can be used in resuscitation. This is a first line in resuscitation, especially in patients with burn and trauma. This is out of the pediatrics, actually. But in pediatrics. In dehydration, due to the most common example is the GI loss, vomiting and diarrhea. It is used in resuscitation. If there is no normal saline, you can use the ringer lactate. And sometimes you can use ringer lactate safely. Now, the other indication is in acute blood loss. So hypovolemia due to acute blood loss, because this is, as we said, it is the nearest physiologically to the blood or to the plasma, we can give it. Other indication is in hypovolemia, as we said, in GI loss, that's mean in diarrhea and vomiting, and in third space fluid shift, like what happened in, this can happen in burn, in ascites, in pleural effusion, in pericardial effusion also. We can, if it's severe to causing hypovolemia, it can be used in electrolyte loss and metabolic acidosis. Metabolic acidosis, it's against metabolic alkalosis. And we will know what is the contraindication to use ringer lactate in metabolic alkalosis. Now, the caution in patient with renal failure. Why? Why it is cautiously used in patients with renal failure?
Because it contains potassium?
Yes. Although it is a low concentration just 4 milliequivalent per liter, but in those with renal failure, it's not contraindicated because it is a low amount or low concentration. It is cautiously used. So we should check the potassium of those patients either by checking the serum potassium before and after, or by checking or by doing the ECG to show the changes of the potassium according to it. Now, contraindications. We have 2 major contraindications to use the ringer lactate. The first is in cases of none or probable metabolic alkalosis. And the example is, as we mentioned before, is the isolated vomiting. Isolated vomiting always causing metabolic alkalosis, and we know why. And in cases of liver disease, if there is a liver impairment. Why? Because in metabolic alkalosis and in liver disease, the lactate that found in ringer lactate after introducing into the circulation, it will convert it to base. It will convert it to bicarbonate, and this will worsen the alkalosis. So, in metabolic alkalosis, of course, you will add a burden, while in liver disease, because there is an impairment of the metabolism of the lactate, it will convert it to the base, as I said, and worsen the alkalosis. The other contraindications is in cases of hypernatremic dehydration. In hypernatremic dehydration, and you want to resuscitate the baby with hypovolemia, but after doing the clinical examination and after even doing the investigation, you are sure your patient is hypernatremic dehydration. It's contraindicated to use it. It's better to use, or you should use, normal saline. Why? Because if you remember the concentration of the ringer lactate in comparison with the normal saline, or its osmolarity, it's considered as hypertonic. And if we give it a resuscitation, it will cause a rapid decrease in the serum sodium. And this is against the guided management to lower the hypernatremia and those with hypernatremic dehydration. So, especially if we use it in multiple fluid boluses, and those patients with hypovolemia and need more than 1 bolus to give it, so it will cause rapid lowering, and that's better, or you should use the normal saline, and here is contraindicated. Now we will go to the other type of fluid, which is the 5% dextrose. By the way, what we mean when we say 5% dextrose? What does this 5% mean? %, 10%, percent of what?
Concentration.
Of course, percent of glucose, but what is the meaning of 5%? Or 10%, or 20, or 50?
يعني مقارنة بالووتر يعني؟
مقارنة شنو؟ No. 5% it means the concentration of glucose inside this solution. This is just هي شنو مقارنة لازم نعرف هاي 5% شنو 10% شنو؟
يعني الأوزمولاريتي مقارنة بالفلويد اللي هو موجود به.
You answered wrongly and you should stop.
Okay.
When we say 5%, you know this fluid contains just glucose and sterile water. 5% it means 5 gram of glucose in each 100 ml of sterile water. 10% it means 10 gram. 20% it means 20 gram. 50% it means 50 gram in each 100 ml of the water. So for this bag of IV fluid, this is a 500 ml. What is the concentration of the glucose here?
20. 25, Doctor?
25, yes, 25. So this is isotonic fluid because its osmolarity within the range between the 250 up to 375. And as we said, it is of course crystalloid. But according to its use, can we classify it as a resuscitation fluid or replacement fluid or maintenance fluid?
Not
Fluid.
Not resuscitation?
No.
because it's hypertonic.
Hypertonic? لا بابا, this is isotonic. استوي ده أقول. This is isotonic.
It will be metabolized in the body, so it will become hypotonic.
Very good. Very good. This type of fluid, although it is isotonic, because the osmolarity within the range by the presence of this concentration of glucose. But once this fluid is infused, it contains just glucose. The glucose will be metabolized, will be consumed, and the remaining is just sterile water. And of course, sterile water is absolutely hypotonic fluid. So we cannot use it in resuscitation because of this criteria or because of this feature. Now, uses of glucose water. We can use glucose water for maintenance, not for resuscitation. Those patients that cannot take anything by mouth. An example is, just one example for those patients cannot take anything by mouth, and we should give them 5% dextrose. Give me an example.
External obstruction.
دكتور that can comatose patient.
دكتور بوست اوبراتيفلي ممكن.
Very good, very good, very good. The most correct example of those is in post-operative. Patient is well, but he cannot take orally. So the fluid of choice is to use the glucose water or dextrose 5% water because it maintains the water balance with a glucose, water balance. So it make a hydration, maintain the hydration for those patients. It's used in patients with acute kidney injury because it contains just the glucose. There is no burden on the kidney of the sodium chlorides. So it provides free water for the kidney. The kidney needs free water for hydration, for diuresis, for enhancement of its function in acute kidney injury. So that's why we give 5% dextrose for those patients. And this will aid, as I say, it will enhance the movement, the function, so it will aid in renal excretion of the solutes. And we will now add a further solutes on those patients with impaired kidney, especially in acute kidney injury. The 5% dextrose, which is a 5 gram in each 100 mol, the calories provided by this amount of the glucose is just 170 kilocalorie. And this is, of course, is not a good or enough nutrition source of prolonged use. So those patients he cannot take orally, like a comatose patient. I hear someone, he say, comatose patient. We cannot use glucose water for them. Unconscious patient, because they need a prolonged use. And the calories provided by glucose water is poor, just 170 kilocalories per liter. As we say for post-operative fluid and even for preoperative, sometimes the patient needs to be prepared for the surgery and stop the oral feeding, and you will put on the glucose water. And may be used to treat hypernatremia due to poor water loss. Here is the hypernatremia. You know the diabetes insipidus. This is the example for what I said. Because of poor water loss, there will be a high maintenance water, free water to the circulation. Of course, you will correct the hypernatremia. Dilution of the circulation, it will cause correction of the hypernatremia. These are the uses of glucose water 5%. But, of course, there are contraindications for the use. The first is, which contraindication? First contraindication. Now you can answer from the talk we just talked about. I will not wait. In resuscitation. In resuscitation, it is contraindicated. Why? Because it will convert it once to just a sterile water. So this is absolute hypotonic fluid. And the hypertonic fluid not used in resuscitation. Patients with known or suspected increased intracranial pressure. For the same reason, glucose water regarded after entering the circulation as a hypotonic fluid. So of course it will increase the cerebral edema in those patients with suspected or proven or known increased intracranial pressure. And if we use it with the same line with the blood, it will cause hemolysis. This is for the 5% dextrose and all multiplications of the glucose concentration. It will cause hemolysis. So these are contraindications to use dextrose 5%. Now we will go to other type of fluid. According to osmolarity, what is this?
Hypotonic?
Hypertonic.
Hypertonic, because this is called half normal saline. The concentration of the sodium chloride is half of that in normal saline. Of course, its osmolarity is less than 250. So this is a hypotonic fluid. Hypotonic fluid has also indication, caution, and uses, and even contraindication. If we go to the uses, anyone can tell me what are the indications of use of hypotonic? when we can use hypertonic fluid?
And treating hypernatremia?
Always the answers come from the guys, from the male. Where are the females of the group? Why you are silent? Ladies of the group, why you are silent? Okay, what do you say?
Treating hypernatremia?
Treatment of
Hypernatremia.
treatment of hypernatremia. Okay, we can use the treatment of hypernatremia. Yes, I will classify the uses of the hypertonic fluid according to the type or according to the site of the dehydration. Now I know you know the dehydration classified according to the osmolarity types, hypertonic, isotonic, and according to the severity or according to the levels we have mild, moderate, severe. And this is a new term, which is the site. What is the site? This is meaning if the dehydration happened intracellularly or extracellularly. So when you answer, it is a hypernatremia, can be used in hypernatremia, this is correct. This is a type of extracellular dehydration. There is a hypernatremic dehydration. In the sessions of the dehydration, we will talk why the hypernatremic or from where the hypernatremic dehydration arises. So if we say there is extracellular, of course the other is cellular or intracellular. So what is the intracellular dehydration conditions? Can you give me an example for intracellular dehydration conditions and how it happens? Very good. DKA, diabetic ketoacidosis. And the other example I will provide you is the hyperosmolar hyperglycemic state, or they can call it a hyperosmolar non-ketotic coma that happened in type 2 diabetes mellitus. Although this is rare in pediatrics, but it is another example of the intracellular dehydration. So the problem here is hyperosmolarity. Hyperosmolarity of the circulation, like what happened in diabetic ketoacidosis or in the hyperosmolar hyperglycemic states. And this hyperosmolarity didn't happen because of a high concentration of the sodium. There is nothing wrong with sodium, but because of the excessive diuresis, there is an excessive diuresis. So and because of the high, the presence of the high blood sugar will cause osmotic diuresis. So there will be an excessive diuresis in that cases or in those cases. So there will be what is called an intracellular dehydration or hyperosmolarity. And when we use the hypertonic fluid, of course, we will correct this hyperosmolarity. Hypertonic, correct the hyperosmolar. The other example, it is the extracellular dehydration, or it is the dehydration, hypernatremic dehydration, that can happen like gastroenteritis. In the cases of dehydration, this is called the extracellular, because the problem is inside the circulation. The problem is inside the circulation. There is a high level of serum sodium because the loss of a fluid is more than loss of a fluid or loss of water is more than that of the sodium. So the result will be hypernatremic dehydration. So we can use it for these indications. While the contraindications, this is a hypertonic fluid. So in those patients with risk of increased intracranial pressure, of course, we can't use it because it will increase the cerebral edema. And in those patients with liver disease, with trauma, with burn, also we can't use the hypertonic fluid, whether it is the half normal saline or its derivatives. Now we hypertonic fluid or in half normal saline. This means we can use it, but we should put these in our mind. Like what? It may worsen the existing hypovolemia and hypertension, causing cardiovascular collapse. Anyone can tell me how, if we give an IV fluid, hypertonic fluid, may worsen the existing hypovolemia and causing hypertension? How?
Doctor, by
Does it work more
extravasation.
So one, please, when you hear your colleague start to answer, so wait him. What do you say? One of you, please, one of you, re-answer.
Hello, Doctor, تسمعني؟
Yes.
Doctor, because of extravasation.
Extravasation? What do you mean by extravasation?
Because it's hypotonic, so it will leave the vessels.
You mean the shifting of a fluid from the intravascular to the intracellular and to the so it will cause or worsening the hypovolemia. And this is correct. Yes, you are right. And of course, this will lead to hypertension. And if there is a worsening of the hypovolemia, well, there will be cardiovascular collapse. This is that happen normally or physiologically in the hypertonic dehydration. In hypertonic dehydration, that for those patients coming to us, and naturally or principally or primarily with hyponatremic dehydration, we find them with worsening signs of dehydration because of the movement of the fluid into the intracellular compartment. So the signs of dehydration will be worsened more than in isotonic. And the opposite happened in hypernatremic dehydration. Because of the shifting of the fluid from the intracellular to the extracellular, so there will be a partial preservation of the intravascular fluid volume, and the patients with hypernatremic dehydration always presenting late when it becomes really severe. While for hyponatremic dehydration, they can present it early. So this is the first consideration. It may worsen the existing hypovolemia. The second is it may cause a fluid overload. Now may cause fluid overload, resulting in decreased electrolyte concentrations or overhydration. This is meaning at the beginning of given or infusion of the hypertonic fluid. It may cause a fluid overload and decrease electrolyte, of course. Patient, he may be, has hypokalemia or has hyponatremia because of use of delusional and overhydration. And of course, if there is volume overload, it may be reflected as congestive heart failure, especially as pulmonary edema. It should be used in caution in those patients with heart failure for the previous reason, and in those with severe renal insufficiency, because it may cause fluid overload, and in those with edema with sodium retention. Although it is low in sodium, but it may add burden to those with edema and in sodium retention, and this can happen in some patients with severe renal insufficiency, especially in those with oliguric phase. They have edema and sodium retention. And if we give it in rapid infusion, it may cause hemolysis. Why? Because of the swelling of these RBCs. Then rupture, so causing hemolysis. Now we will go to other type of a fluid. Can you tell me what is this fluid? أحمد عبد الرزاق ممثل الجروب، سمعنا صوتك.
نعم دكتور.
ممثل الجروب يعني العقيد يصير، شايف العقيد؟ والتاء ابو شهاب غير الصير ابو شهاب من صدق. يلا what is this fluid؟
3% normal saline.
عافية يا يعني شنو 3% normal saline؟
يعني ثلث
ثلث 3%.
3 times the normal saline.
So this is يعني هسه I want you to classify this fluid according to its osmolarity. What do you say?
Or hypertonic.
Of course, this is hypertonic fluid because this is a 3 times the osmolarity of normal saline, and the sodium chloride, its concentration will be 3 times that of the normal saline. Well, half. 3%, it means 3 times. So the osmolarity of this fluid, it is, شوف الosmolarity وين صاعدة. احنا قلنا anything is more than 375 is hypertonic. So here is more than 1000 milliosmol liter. This is used in a narrow situations. This is with restricted use. Not always we use it. In certain cases, restricted use. So it's used in treatment of severe, critical, symptomatic hyponatremia. And those with hyponatremia, in management, we will see it in the session of the dehydration and fluid therapy. In the management of the hyponatremic dehydration, we use in resuscitation normal saline. And we use in the replacement and maintenance the hypertonic fluid, but not with 3% normal saline, especially in pediatrics. 5% dextrose and half normal saline is enough. But in those with severe critical symptomatic hyponatremia, give me 2 symptoms for those with severe critical symptomatic hyponatremia.
Common
Seizure. Very good. Disturbed level of consciousness, or even coma. These are severe critical symptomatic hyponatremia. So in those patients, we use a 3% normal saline. It may cause a fluid volume overload and pulmonary edema. Why? Because this is a hypertonic fluid, and it will cause shifting of the fluid or the water from the intracellular compartment to the extracellular. So inside the circulation causing fluid overload, interstitially causing pulmonary edema. You know, interstitial, it's also meaning extracellular. So it is contraindicated in patients with heart failure and renal conditions. Again, because it causes fluid overload and it causes pulmonary edema. And of course, in those with renal conditions, this is a high load of sodium chloride, especially the sodium. So how we can use it in those with renal impairment? Of course, this is contraindicated, not cautiously, contraindicated. So it is given slowly and cautiously for those patients needed it. I mean the severe critical symptomatic hyponatremia. To avoid the intravascular fluid overload, spontaneous hemorrhage. And if we give it rapidly, we may cause hypernatremia, rapid correction of hyponatremia causing hypernatremia, and hyper or hyperchloremia. We have normal saline 5%, and we have also 7%. But 7%, it is usually used in animals, not in a human. This is 5% dextrose and 0.9% sodium chloride. So, what we can call this type of a fluid?
Hypertonic.
Hypertonic.
This is a hypertonic because the combination of two isotonic fluid making it hypertonic. And hypertonic fluid used clinically in which indications? Hypertonic fluid like that. 5% dextrose, given the maintenance.
Glycemia.
Hypoglycemia. Wow. Hypoglycemia. The hypoglycemia are hypoglycemic, so you have to replace them with glucose, and 5% dextrose is not enough to correct the hypoglycemia. The answer is this type of fluid used in maintenance and used in replacement. And the example is in treatment of severe dehydration. After correction of hypovolemia, after resuscitation of the intravascular fluid, we will go to the second step of the management, which is the replacement of the deficit of fluid and maintenance of the daily requirement. And the best fluid used is 5% dextrose in normal saline, but this is out of the pediatric. In pediatrics, we use 5% dextrose in half normal saline for those more than 10 kg of weight, and 5% dextrose in quarter normal saline or 1/4 normal saline in those less than 10 kg. So this is what I mentioned, used as maintenance as replacement of fluid in pediatric more than 10 kg of fluid. And this is the 5% dextrose in quarter normal saline, used in those less than 10 kg. All these are hypertonic fluid because the combination of either isotonic with isotonic or isotonic with what we mentioned before, which is the Langer plus 5% dextrose. So again, lactated ringer or ringer lactate alone is an isotonic fluid, but when we combine it with 5% in one solution, it will give us type of fluid which is called the hypertonic and used in maintenance. So those types of fluid, all we consider as hypertonic. The 5% dextrose and normal saline and its derivatives, and the ringer lactate with the glucose. We can use it in the management and the maintenance and replacement, and in hypovolemias. Of course, when we say maintenance and replacement for those patients with loss or with deficit. And this is providing us with calories because of the presence of 5% dextrose, of course water, and electrolyte because the presence of the sodium chloride, and in case of the ringer lactate, also we have potassium and calcium. And this is, as we say, used as maintenance IV fluid. But the caution in use hypertonic fluid of that type is we should monitor closely the fluid overload. Yes, because this is hypertonic, causing increasing the intravascular volume until it will maintain the osmolarity between both compartments. So always, inshallah, in this session of the fluid and dehydration, we should monitor, close monitoring of our patients after put a plan of management of severe dehydration and given the hypertonic fluid. Of course, to prevent the pulmonary edema, the interstitial edema, and the intravascular fluid overload. Now, this is 10% dextrose. You know, or you remember the 5% dextrose. It is isotonic. And we say the concentration is 5 gram in 100 mol. Here is the multiplications of. So it is 10%. This is meaning 10 gram in 100 mol. And of course, it is isotonic or hypertonic? Hypertonic. Hypertonic. So, give me an example for the use of this type of a fluid. 10% dextrose. It is used daily as in a
severe hypoglycemia.
daily. يعني احنا daily عندنا severe hypoglycemia. Post-operatively 5% dextrose لأنه isotonic. You give hydration, maintain the water, and give the accepted source of calories because of short use. بعدين patient can take orally. But 10% dextrose is daily use in the neonatal intensive care units as a maintenance fluid for the neonates in the first 48 hours of life, in special or in certain amount or dosage according to the weight and the prematurity or the gestational age of that patient. So in the first 48 hours of life, the kidney is not fully mature, even for the full-term baby. The kidney is not fully mature in its glomerular and the absorptive function. In that period, the first 48 hours, if we go after asking about the exact age of the baby from the history to manage, after asking what is the age, we will select the type of a fluid. So if it is less than 48, just 10% dextrose we can give it. After that, we can start with the 5% dextrose in quarter normal saline or in fifth normal saline, 0.18. So in the first 48 hours, as I said, the kidney cannot filtrate or reabsorb the sodium and the chloride. And the only fluid used here is the 10% dextrose. It will prevent the hypoglycemia in that patient. Because we say the 5% dextrose, it is just 170 kilocalorie. And this is a poor source for calories. For prolonged use, this is 48 hours, and this patient cannot start feeding, so need a hypertonic fluid, which is the 10% as maintenance. And sometimes if there is hypoglycemia, we may increase the concentration more than 10%. The 10% dextrose can be used through the peripheral veins, through the peripheral cannula. But if we go to hypertonic, more than 10% dextrose, we should change the line of infusion of this fluid. So this is a 50% dextrose. And you can see here, in 1 mol, they have 0.5 gram. And the 25% dextrose, these examples of hypertonic, should be used, of course, this is used in the hypoglycemia. Whether in hypoglycemia, neonatal hypoglycemia, whatever the cause, or in hypoglycemia that happened elsewhere, in pediatric or even in adults. But hypertonic, if it should be given directly, not infused with fluid, it should be given through the central vein, because if we give it through the peripheral vein, it will cause thrombosis and phlebitis, or causing thrombophlebitis. And again, as we said before, the given of the dextrose 5% and its multiplications, it causes RBC hemolysis if it is used, or blood hemolysis if it is used the same line with the blood. So it should be given in separate line. This is the hypertonic. Now we will go to other type of a fluid, and of course you heard about it, which is 20% mannitol. Do you have an idea about mannitol? What is mannitol? Its classification according to the tonicity. Is it a crystalloid, alkaloid, indication, caution?
دكتور يستخدموا بالاي سي بي، يعني يسوي اوزموتيك ديفرنس، فيعتبر كدايوريسيس بهالحال.
So what is how the mannitol can cause or use an increased ICP? Yes, you are right, but how?
نعم، يسوي شيفتنج للفلويد من انتراسيلولار للاكسترا، لا بالعكس راح يحركها من انترافاسكولار للانتراسيلولار.
And this will cause increase the intra.
لا بالعكس من انتراسيلولار
Okay, it's clear. Look at me. Look at the screen, of course. The hypertonic fluid, its osmolarity is more than 375. This high osmolarity can be achieved by high concentration of sodium chloride, like what we see in the 3% normal saline or 5%, or sometimes because of the presence of high level of glucose, causing it a hyperosmolar, increase its osmolarity. So this is another example of a hyperosmolar fluid. Of course, it is crystalloid. And here, this fluid, its active ingredient is a sort of what is called a sugar alcohol that is called the D-mannitol. This is an alternative to what is called sorbitol. Sorbitol that's used as sweeteners and those, especially used in those patients with DM. So it's called sugar alcohol. This sugar alcohol and its concentration is 20%, and you know what we mean. It means 20 gram and 100 ml. When we see percent, it means 100 ml. And the 20, it means 20 gram. 5, it means 5 gram, and etc. So this mannitol, we say it is a sugar alcohol. It will induce the diuresis. Which type of diuresis? It is called the osmotic diuresis. It will increase the osmotic diuresis. This way, it will decrease the cellular edema. So that's why it is used in management of those with increasing intracranial pressure or cerebral edema. More information about mannitol, 20%. As I said, it is an osmotic diuretic. The active ingredient is called sugar alcohol. And it will elevate the blood plasma osmolarity because it is hyperosmolar. So the primary action is to increase the plasma osmolarity. When the plasma osmolarity will increase, what will cause? Anyone can tell me?
For shift of a fluid from intracellular to extracellular compartment.
Very good. So we increase the blood plasma osmolarity to making the fluid that is intracellularly accumulated, causing edema, to be shifting from that compartment to the intravascular compartment. After that, it will induce the osmotic diuresis. So, as a result, cerebral edema, elevated intracranial pressure, and the CSF volume will be reduced for this movement. Then the beneficial effect, it will be the reduction in blood viscosity because of the movement of a fluid. Then the osmotic diuresis will lead to a loss of this fluid. So, complications of using mannitol. Patients may have rebound edema after stopping giving mannitol, or sometimes there may be dehydration. يعني الشغلة تروح وين؟ Correction of the cerebral or intracellular edema, but because of osmotic diuresis will cause loss of fluid more than planned by the action of mannitol, causing dehydration, and it may cause, because of dehydration, it may cause renal failure. Mannitol also can be taken orally, and it will increase or it will induce osmotic diarrhea. And this can be used practically. This is not a scientific way, but practically used in those patients post-operative, and they didn't pass motion after a certain time after the surgery. So they gave them just 1 cup or about this through the mouth to induce the osmotic diarrhea. So mannitol has the effect of this. Now, this is to remind you, this is the 5, or this is the types of a fluid. When we say isotonic, so what comes to our mind is the normal saline and the ringer lactate. Isotonic, there is no shifting of a fluid. Used in the resuscitation. Hypertonic comes, dextrose 5% comes to be hypertonic, because we know the cause. Metabolism of glucose, so it's absolute hypertonic. And for that reason, we cannot use it in those with head trauma, with cerebral edema, or with increased intracranial pressure. And the hypertonic, and the example here is the 5% dextrose and a half normal saline, or a normal saline. This is used as the maintenance of fluid, but it may increase the intravascular volume. So it should be monitored closely to prevent the fluid overload and to prevent the pulmonary edema. Now we will go to other category of the fluid. Then we will finish, which is the colloid. And we say the colloid is 2 types. We have a natural colloid, like the albumin, and we have the synthetic colloid. So for albumin, it is a 5%, and we have 20% or a 25%. And now I think it's clear what we mean by 20% or 25% of the percent. So now I need to repeat. This is the albumin. Now, what is the indications of albumin use? يعني هسه إذا تجمعون منا ومنا تجاوبون صح. نعم؟
هايبو البومينيميا بالرينال فيلر.
هايبو البومينيميا and renal failure. يعني هو renal failure. renal failure. هايبو البومينيميا.
Nephrotic syndrome.
So, in cases of hypoalbuminemia in general, hypoalbuminemia, hypoproteinemia, and mainly hypoalbuminemia, it may low concentration of albumin. Maybe through nephropathy, nephrotic syndrome, or it may be enteropathy. So, I mean protein losing enteropathy, and the example is for protein losing enteropathy.
Cerebral disease.
Inflammatory bowel disease, very good. Or the بعد عندنا low intake of albumin. Sometimes there is a low intake of albumin, or in chronic liver disease, the patient may has hypoalbuminemia. So either from space to analyzer, like what decrease size or causes hypoalbuminemia, and in cases of even severe profound precardial. So and neck syndrome, and it can be used sometimes in the case of the acute and it can be used in nephrotic severe hypoalbuminemia cause generalized edema, that's called the anasarca, and we can use it in neonatology. Albumin has indication to use in neonatology. Do you know it? Do you remember it or not? Albumin.
Plasma exchange ممكن.
No. Plasma exchange, but not in a neonate. In a neonate. In management of severe hyperbilirubinemia, given albumin, because sometimes the problem is deficiency of albumin, and those patients, you know, the albumin is the carrier protein for the bilirubin that carrying it from the spleen to the liver for the metabolism, for the conjugation. So we give the albumin to increase the carrier proteins, and it is a trial to decrease the level of TSP before doing blood exchange, not plasma exchange. So we will review the indications. Fluid resuscitation. You know, this is an isotonic fluid. This is, sorry, it's not an isotonic, but it is a high molecular weight, large particles, cannot cross the semi-permeable membrane cells, so it will lead to increase the intravascular volume or increase the plasma volume. So it's used as fluid resuscitation, but should not be used as the first line. All the colloids should be the first line in the fluid resuscitation. Significant hypoalbuminemia, and we talk in details about the causes. Nephrotic syndrome as an example, and in therapeutic plasma exchange, or what's called the TPE. Or sometimes they call it the plasmapheresis or apheresis. So, do you have any examples for the conditions for the plasma exchange? Therapeutic plasma exchange.
Guillain-Barré syndrome.
Very good. So if we can categorize them into the systems, so in CNS, like in Guillain-Barré syndrome, or the correct pronunciation is Guillain-Barré, not Guillain-Barré. This is Iraqi way, Guillain-Barré. It's Guillain-Barré. So, and in a chronic and inflammatory demyelinating polyneuropathy, and in myasthenia gravis, and in multiple sclerosis, and even in Sydenham chorea. Do you know the Sydenham chorea?
Yes, an infective
Sydenham
endocarditis.
chorea.
عفوا rheumatic fever.
And rheumatic fever. Yes, and rheumatic fever. So in these conditions, I use the therapeutic plasma exchange. Hematologically, we can use it in ABO compatibility for those with bone marrow transplantation, or we can use it in the autoimmune hemolytic anemia, or even aplastic anemia, and in pure red cell aplasia, and we have another or further causes. So if we go to the renal causes or nephrologic causes for plasma exchange, we can use it in the lupus nephritis, we can use it in focal segmental glomerulonephritis, and even we can use it in hemolytic uremic syndrome. So if we can go to the rheumatology. Rheumatologic causes. We can use it in SLE. We can use it in rheumatoid arthritis, and we can use it in scleroderma. These the indications. And we can use it in acute hepatic failure, and we can use it also in renal transplantation and heart transplantation. I mean, in cases of rejection. And sometimes even there is poisoning with certain drugs or overdosing of certain drugs, we can use the plasma exchange. All these conditions, we can use the plasma or therapeutic plasma exchange. So here, albumin is used. In cardiothoracic surgery, as pump prime for cardiopulmonary bypass, and in excessive protein loss or replacement of adrenal losses, we talk about these causes or examples. And in burn and fluid replacement for burns, we use the albumin. And finally, in the liver transplantation, where the post-cardiac surgery, sometimes the patient has what's called the chylothorax. You know the meaning of chylothorax. It's the accumulation of the lymph inside the pleural cavity, so you have to give albumin. This is example of the synthetic colloid fluid, which is called the Hemacil. And you can see here the concentration or the compositions. It contains sodium, potassium, chloride, and calcium, but it contains an active ingredient of it, which is the high molecular weight. It's called the polygylene polypeptide. This is, so sometimes they call it gelatin. This is making it colloid, and it can be used in cases of the rapid expansion. It's called volume expander or plasma expander, but it is rarely used now, and it can affect on the cross-matching of the blood. يعني notable hypovolemia due to blood loss. يعني a major indication blood loss or plasma loss. لكن we're not in cases of dehydration or hypovolemic, whatever the cause. لكن it may affect the cross match. So it's nowadays, and if you want to give blood to the patient, so draw blood for a cross match before giving the Hemacil. Nowadays it is, in our practice, it's out of use. And this is called the dextran. Dextran, we take it as an example of hypertonic, but it is a colloid fluid. It's not a crystalloid. And also it may affect the cross-match, and of course it is increasing the intravascular volume. And this is the plasma. And the plasma, as we said, it is an example of natural colloid. And inshallah, in a separate session, we will talk about the blood and the blood product, the transfusion, and we will talk about the plasma and the indication of using the plasma and how to use it. This sheet showing the different types of a fluid, the description, the osmolarity, the use, and the comments about it. It's better to review by you. And this is the abbreviations for the IV fluid. You should keep it in mind, because you will deal with the fluids in your practice in this way. D5W, NSS, half NS, LR. So you should be prepared on these abbreviations. And now we reach to the end of our session. Thank you. Do you have a question?
Yes, doctor. We said that
I know the cause or how this occur.
We said in DKA there is a hyperosmolarity of the intravascular volume because of what? Hyperosmolarity of because of presence of high blood glucose, and this will cause diuresis. This will cause diuresis. excessive diuresis, and the patient will have dehydration. So there will be shifting of fluid from the intracellular to the extracellular to make a partial correction for that condition. So that's why they call it intracellular dehydration. The primary problem is in the high blood sugar, causing high osmolarity, induce excessive diuresis, so there will be dehydration, causing the movement of the fluid from the intracellular to the extracellular. So that's why this is a cellular or intracellular dehydration. Is it clear to you now?
واضح شكرا دكتور.
Yeah. Another question? هي يعني فيزيولوجي حلو